Hi, good afternoon, everybody. Thank you for joining us today. My name is Adam Fabrizi, and I am with Court Quality in Real Time. We're excited to be able to partner with Cinzy for today's presentation. Cinzy is a company there's some of you on the call today may be very familiar with as a name out in the industry, and if not, you definitely will be familiar with them after today. So we're excited to be partnering up with them to bring you today's presentation. A couple quick housekeeping notes. If you do have any questions throughout today's presentation, please do utilize the question tool. It's in the lower part of the GoToWebinar tool here. We're going to try to get through as many of those as we can, time permitting, toward the end of the presentation. But again, if you do have any, please be sure to use those, and we'll get to those as we can. So also the slides and any other handouts from today's presentation will not be made available or sent out. However, a recording will be shared with all attendees. That typically goes out about 24 to 48 hours following the conclusion of today's presentation. Also, contact information will be made available in a second here and also at the very end of the presentation. So if you do have questions, if you want additional information about either of our organizations, please do reach out, and we'd be happy to have that conversation with you. It's just about everyone in the home health field and really the post-acute space in general these days has been severely impacted by the current COVID pandemic. The concept of telehealth and virtual care obviously becoming more prevalent than ever in this space. And as you'll hear today, both the definition and really the delivery of telehealth and virtual care continues to evolve and expand. So today's presentation, titled Embracing an Era of Innovation, Virtual Care and Telehealth in Home Health, is presented by Michael Pepe, who's the Director of Solutions Engineering at Cinzy, and also Shelley Eggleton, who's our Director of Clinical Consulting at Court. Both offer a vast amount of knowledge and insight on this topic, and we're excited to have both of them join us and share their wealth of knowledge with us here today. So without further ado, I'm going to go ahead and turn it over to them.
Thank you, Adam, for that wonderful introduction. And I also want to welcome Michael. I just met Michael a few weeks ago when I had my own Cinzy demo, so I'm very happy to be co-presenting with him today.
Thank you, Shelley.
You're welcome, Michael. I have a short story that I want to share with you that I think is really quite appropriate for today. The day after I had the demonstration with Cinzy, I had my own personal experience with virtual care. My husband needed to see his physician, and he didn't want to go to the office because we live in rural upstate New York, and his primary care physician is an hour away. And so when he contacted the physician didn't think that he needed to see him either. And so he set up a virtual care visit, totally acceptable under the circumstances of what my husband needed. So I just wanted to bring that to you as an example that's very appropriate. And here's technology that saved time and money on everybody's part. Okay, so now on to our agenda. We're going to talk about the on-demand world, and and especially what that means with COVID-19 as well. And then who is Cinzy? We're going to provide you with some virtual care examples, and then what we're seeing in the field from the patient and the agency perspective. And then Michael will discuss with you too how easy it is for clinicians in the field to use this technology. Talk about the learning curve, especially when they're already so pressed for time in their day. We'll also bring about and discuss some stumbling blocks and ways to combat these, and then how reimbursement has worked with telehealth so far, which we know has not really been great, but we'll discuss more of that because there's good news coming. Okay, Michael.
Yep. So thank you again, Shelley and Adam, for having Cinzy here today. We're excited to be here. So, we figure we start out in the current world that we're living in today, and the world really has changed over the past decade. If you start to think about the way you interact in your everyday lives, we really live in a consumer on-demand world, really, except for healthcare. So think about your shopping experiences, most likely to take place on Amazon, possibly taking an Uber or Lyft over a taxi today back from the airport, or even how we watch movies, really on Netflix, any of your streaming services, as opposed to, going to the big box store, a Blockbuster. So patients really want to interact and communicate in healthcare the same way they would in their everyday lives. And that's really what we found true over the past couple of years.
And so I'm just going to touch a little bit on healthcare yesterday and healthcare today. And probably this is appropriate for me since I was in healthcare yesterday and can remember when telehealth units were rather large units. They were bigger than like a phone console. They had 3 or 4 peripherals. And as a clinician, we had to be crawling around on the floor looking for outlets. Often it took 2 or 3 visits sometimes for the patients and or their caregivers to even get comfortable with the technology. We had a telehealth champion that sat in the office all day looking at the results as they came in. He would contact the patient or the physician if necessary. But a lot of times it kept the case managers totally out of the loop with what was going on with telehealth, unless there was a problem. And then we also had patients that we couldn't use telehealth units on because of the environment. And I can tell you as an administrator, after once or twice of sending units back to be cleaned by the manufacturer because of roaches or bed bugs, we had to rethink how we used the units because the expense of cleaning was more than the margin that we made on the episode. And you can't do that too long and still stay in business. And as far as healthcare today, the innovative technology that we have available today moves us to an entirely new realm, a realm of virtual caring, or I just recently heard someone say, and I love this, telecaring. And I believe we should embrace it as such because we can offer frequent touch points. We can actually see our patients without having the expense and time consumed of traveling and being at an in-home visit. The entire concern about leaving a unit, leaving the units in patients' homes goes out the window. And especially right now, amid the COVID-19 crisis, and for how long, I don't believe we really even know, that I'm hearing that from many clients, that patients are declining home visits as much to prevent, infection from coming to them. And they don't want people in their homes, and they don't want to spread infection to their other family members. So I see home health using virtual care for patient and caregiver education, coordination of services among disciplines, wound care consultation with a physician, and it's a perfect use and CMS sanctioned with a waiver to conduct a physician face-to-face using a virtual care technology. So, and I've also heard therapy visits being done, and I'll speak about that a little bit later too, along with the live Oasis reviews that we're offering at Court now. And before I move on to the next slide, I just wanted to add this one final bullet, and that is that technology has been a valuable partner for home health for many years. Many agencies have demonstrated improved outcomes in the realm of rehospitalization and emergency department use. And future partners will look for agencies who will use technology to improve not only patient outcomes, but to improve overall efficiency and in operations, because that in turn decreases everybody's costs as well. So Michael, I'm going to turn this over to you for the next slide.
Excellent. Thank you. So, I figure I'd spend just a minute or two briefly on Cinzy and what we do for all those folks that aren't too familiar with telehealth or virtual care. And, telehealth is a word that's used broadly. And, as we start to get into the presentation, it's really a lot more than telehealth. It's really communication and everyday communication between patients and clinicians. But Cinzy is a cloud-based technology company based in St. Petersburg, Florida, and our sole focus is on healthcare. Majority of our clients are on the post-acute side, so we do not span into any other industries or verticals, like a lot of other video vendors that you might see out there that might be in financial services or education. We're just solely focused on healthcare. We run on everyday devices, so we're really going to talk about that more, what we're seeing in the field later on that really makes a big difference, not having to go out and purchase any additional hardware. And the idea of the platform is really to facilitate effective care over distance. Okay, so Cinzy can also service limited English proficient patients, and we also service the deaf and hard of hearing patient population as well. All our data is encrypted and at rest. I know this is a pretty hot topic of what's been going on the past couple months. So, utmost importance to us of security, whether it's the virtual video or the patient data within the platform, is high trust certified. So, Shelley, if you don't mind going to the next slide, please.
Mm-hmm.
Okay, so I'll just spend a minute here just how telehealth works in general and, really how it pertains to Cinzy and just virtual care. So Cinzy, think of us as just an all-in-one comprehensive communication platform, okay? It allows clinicians and patients to communicate the same way they would in their everyday lives. We're not built as a transitional EHR or documentation system. We're going to address that later as well, too, to not interrupt clinical workflows. The platform enables clinicians to communicate with colleagues via virtual visit, secure messaging on any device. And then on the patient side, Cinzy allows for bidirectional communication in a couple different ways. So the clinician and patient are able to conduct a virtual visit, secure message, text, email, as well as automated programs, which are interactive with assessments. So think of that as a survey tool. And clinicians also have the ability to engage caregivers or family members. So that's going to come up later as well, too, because that's a lot of what we're seeing in the field. Being able to bring in family members that might not be located in the same state as the patient or just in everyone's everyday busy lives. And I think that's a really important part of a telehealth solution if you are looking for one, for a platform that's able to do that. And then really last but not least, administrators, any sort of administration at the organization has the ability to view real-time data on all activity within the platform. So, absolutely look for a platform that you can audit, track, download reports, and view real-time data within those. Thank you, Shelley.
Mm-hmm. Okay, so there's more good news. So you can see from this slide, and we only put 7 of them up here, but there's many, many different opportunities for you to use telehealth and virtual care and home health. But first and foremost, so virtual care is especially helpful for patients who have wound care. As I stated earlier, you can contact the physician if you have if you need a consult because of a difficult wound, or if you want to demonstrate improvement or decline, something like that. Also, you can contact the wound care center virtually. You could contact your WOCN if you have one on staff, and you can do virtual assessments and consultation right there while you're in the patient's home. And really, virtual care will make taking photographs and required consents and all those HIPAA fears obsolete. I don't believe that there was too much virtual therapy going on prior to the COVID-19 crisis. But I'm hearing that many agencies are performing PT, OT, and ST visits. So no, these visits are not billable. We know that. And they don't count toward the patient's LUPA threshold. But the patient is continuing to receive the care that is ordered while not jeopardizing themselves or the therapist during our public health emergency. And also, the therapist has the ability, when you think about this, to perform many more virtual visits per day than they did if they were in person. So, and also, you don't have the expense of mileage then either. And then for our third bullet for behavioral and mental health, who would have ever thought that we would have been quarantined for this long? People who are unable to leave their homes or have a history of depression can really, really feel socially isolated during these times. I mentioned telecaring before, and now we have technology that we can convey caring. Remotely, we can see our patients and we can hear our patients. And they can see us and they can hear us. We now have the ability to create frequent touch points for patients who don't have family, or maybe they have that history of depression or some other mental illness. And we need to let them know that we care, that we're there for them. Medical social workers can use virtual care technology to provide counseling to patients as well. This pandemic has not affected just our patients. Our staff need support as well. And seeing a smiling face on their phone may be just what they need to boost on themselves during these rough times. And then for chronic conditions, as people age, and more people are aging, thank goodness, because we're all there with them, they're living longer. And also there's the growth in the number of people with chronic illnesses and multiple chronic illnesses. So patients with chronic illness fare far better when they're managed properly. Telehealth or virtual technology encourages the patient to manage their own health care as well. So many patients already have their own blood pressure cuffs, pulse oximeters, they have glucometers, you name it. So teaching them to use this technology and being able to report off to their clinician also helps promote patient self-management. And then patients who are in their palliative stages of their disease process successfully use technology for regular communication with their healthcare team. Home health agencies and hospices are very much part of that team. And technology also plays a role in emergency preparedness. Having the ability to blast out messages, on COVID-19 updates or on weather events or other natural disasters can help prevent your staff from being in unsafe situations. And I'm going to give you an example. I was a home health and hospice administrator in the Southern Tier region of New York State. In 2009, there was a mass shooting that occurred near the downtown area of Binghamton, New York. We had to individually call each and every staff member we believed to be in that area to get out as quickly as they could. If we would have had the ability to blast out that communication to all staff at once, it would have saved a lot of time. Plus, all staff would have received the same message. I think I just got a message that you can't hear me. Is it better now? I hope, Adam, you can let me know that. Okay. I hope. All right, I'm going to go on as if you could. And then something that Quirt started doing last fall was what we termed live OASIS reviews. And this stemmed from an administrator who was frustrated with having poor outcomes and hearing clinicians say that they did not know how to answer OASIS questions properly, even though they had received training. At Quirt, we have clinical documentation educators who are also certified in coding and OASIS. So typically this is how this goes. So when a clinician arrives at home, after greeting the patient and explaining home health and getting consents and things like that, the clinician obtains consent for the patient to speak with the clinical documentation educator, and they conduct an OASIS assessment. The clinical educator makes sure that the OASIS walk is done. They do a tug test or TNETI, whatever it is that the agency requires. And then she guides the clinician in how to properly answer the OASIS questions. This takes about 20 minutes tops. So and it really depends on the needs of the clinician. After the visit, the clinician completes the start of care, and the agency works very hard to get that done and completed within 24 hours. Then the clinical documentation educator will then properly assign codes for this patient and make suggestions for the plan of care development. We usually have a clinician on the program 4 to 6 weeks and then monitor them for a couple of months to make sure the education sticks. Agencies have really greatly reduced their days to wrap with this process, and they know the OASIS questions are answered correctly. Really, your agency's outcomes depend on it. And moving forward, we look to partner with agencies who use virtual care so that we can actually see the patient and the clinician while they're doing the assessment. The agencies have seen great improvement in their accuracy of OASIS answers and their outcomes. Okay, so we're going to move on to our next slide here. So what we're seeing in the field. Michael, do you want to start that off?
Yeah, sure. That's great. So, really what I want to touch on here is that connecting with patients early in the process, whether it's post-discharge or the first couple days that they arrive home, really drives patient satisfaction and reduces readmission. I can't stress that enough. Just thinking back to a couple stories that we've heard over from our clients, the ability to get eyes on the patient, within their first 48 hours of when they're home, because they might not have had home health before and might not know what to expect. So the ability to reach out to someone on their care team within the agency, instead of picking up the phone and maybe just getting some reassurance on a wound in particular, maybe a PICC line, or just some other issue that they might be experiencing that someone can get eyes on real quickly and just reassure them, has really come a long way. A big thing that we're also hearing as well too, and it is, an outdated message, is they're concerned about their patient population using new technology. We really found patients can and will learn. Just seeing in particular the baby boomer generation, and other generations within there, people are getting a lot more comfortable on technology, whether it's, FaceTime with their grandchildren or Facebook. These pieces of technology they're using day in and day out. So the learning curve, and as we get further along in the presentation talking about that, is not as great as you think it would be on the patient side. And then just lastly, family members wanting to be involved. More and more folks are living multi-states apart. And as I mentioned, some people might be living in the same town, but taking care of children, living their everyday lives. So being able to be brought into a conversation if a nurse is at a patient's home and maybe the son or daughter or family member wants to hear the same conversation and be involved in the plan of care, the ability to do that has been phenomenal.
Yeah, I'm just going to add a couple of things here to Michael's bullets as well. As far as the first bullet, COVID-19 has really forced a landscape change for agencies and patients, and decreasing the risk of the spread of the virus is really paramount in flattening the curve. For the second bullet, there is a growing awareness of an interest in telehealth and in virtual care. And I was thinking about this just as Michael was talking. I'm thinking, do we really think anyone is going to, after they've had a virtual care visit during the COVID-19 crisis, is going to want to go back and sit and wait in a physician's office again? Probably not. And again, it's your time, it's money, it's gas, mileage, things like that. And then there are many different areas, and we talked about this before, where telehealth and virtual care are helping patients. And I think of another one too, as far as mental health with cognitive behavior therapy. Again, using social workers and text messaging, medication reminders, just a couple of different, examples how technology can help these patients as well. And then, the whole on-demand access to care, it really enhances the patient-centered care experience. Because in home health, using virtual care technology, clinicians, we have more resources at our fingertips then. So this will help you with new clinicians and clinicians who are new to home health and to hospice. And then it's important for an agency to perform a return on investment when they're considering the technology. But you will save money with travel expense, and you'll also save staff time, and you'll have the ability maybe to resource those staff somewhere else, like bringing more admissions in the door. Okay, Michael, I think this is you.
Yep, and that was a perfect segue, the last bullet point. So, really a few years ago, our industry, the virtual care telehealth industry, didn't have much data to go on. But, the past couple of years and even the past couple months, we've had the ability to compile a lot of data on savings and utilization. Patients are really engaging better than a lot of agencies would think. Virtual care is really not meant to replace all in-person visits, but people's mind always jumped to reimbursement. But the cost savings outside of reimbursement really can't be ignored. So, I kind of just think about another story from one of our clients, down there in the bottom right, 50,000 plus savings in wound care with DME waste reduction. A client of ours working with a couple wound care patients, the ability to get eyes on that patient and figure out they were changing their dressing too often, right? So in a huge waste of product throughout that time. So being able to save money in those aspects, really just up at the top, really better care. So being able to see more patients throughout the day, another story, client of ours in Mississippi, rural Mississippi, only 2 wound care nurses for the state of Mississippi with this one client. So this client had these wound care nurses had to spend most of their day driving all over the state to visit a patient. Now with virtual care technology, the home health nurse can just bring in the wound care nurse whenever they need to and do a virtual visit that way, saving a lot of driving time and a lot of time on the road. On the patient engagement side, that's where I really drive to, that patients are engaging better than agencies would think. I believe something in the number of 90% of text messages just in general are open within the first 10 minutes. So patients are really engaging on the electronic communication side as well too. And, lastly, a lot of people think about ER visits and engagement and drive time, but, just the ability to keep appointments kept, has been a big voice from the field as well too. Whether it's appointment reminders going out by text or email, maybe their nurse just checking in virtually the day before, saying I'm going to be there tomorrow at 1:00. We've seen a big uptick in appointment retention as well.
Good point. And this first bullet, I was thinking, I've not spoken with an agency who's not had a patient deny service during this crisis. And by virtue of the patient needing home care, their health is compromised in some manner, and they'd rather go without care if they don't have to have the ability to receive telehealth or virtual care. And I recently had several hospice agencies tell me that they've been denied access to nursing homes where their hospice patients are being cared for and where they care for their hospice patients. And CMS has come out and said that hospice staff are to be considered as part of the patient care team and should absolutely have access to those patients. And nursing homes should honor those and follow CMS's direction, or at least provide for virtual care visits for those hospice patients. And Michael was right when he mentioned this before about family members. They want to be more involved in the plan of care and the care of the patient. They are willing to use their own devices for patient care. Or if they can't be there, they want to use virtual care for education or care instruction. And then increasingly in the elderly, they're becoming more and more comfortable with technology. I myself have 2 octogenarian in-laws. Actually, he's going to be 90 in just a couple of months. And for Easter, my daughter sent a tablet to them. And we set up a Zoom meeting, and we had family in 4 different states on the call. And we did this again for Mother's Day. Everybody loved it. Now my mother-in-law uses it. We've hooked her up with social media, and she's really right in her glory. So they do come around. Michael, anything you want to add to that?
Yeah, no, that's great. And, relationships are really formed with nurses between patients. So, think of a story, a client of ours in Texas. A patient actually denied service, not because they were really worried about, the virus from their nurses, that they formed such a great relationship with their nurse that they were worried about giving them the virus. So it goes both ways, right? So patients want to keep people they're familiar with safe, and also from a staff agency side, you're wanting to keep your patient population safe. So, if it is really just a quick check-in or that doesn't require an in-person visit, virtual care has been the way to go that we've seen the past couple months.
Okay. And Michael, you want to start this one off?
Yeah, so this one I think will really hit home for everyone. Most of these bullet points, and Shelley, I'll let you touch on a lot of these. But obviously the big thing that I can point out from the results are in slide a few slides back was just really the huge cost reduction. Doing right by the staff, so that's keeping your staff safe as well too. And a huge thing that we hear about is reducing burnout. Right. So, going back to the drive times, going back to the long days, being able to do most of those appointments virtually if they don't require an in-person, has been a huge perspective that we've gotten from agencies.
Okay. And being a clinician, I always try to look at how technology is going to benefit that end user. And every day I hear agencies that are being price gouged for that PPE or the little PPE that they are receiving. Virtual visits can cut down on your need for PPE. And some agencies are accepting COVID-19 positive patients, and some are also preparing for this increase in referrals now that the elective surgeries are beginning to open back up in most states. The CMS says that we can do the initial assessment to determine eligibility virtually or even by phone. However, we must do the comprehensive assessment in person in the patient's home or their living residence. Being able to supplement the minimum number of visits you are making with the virtual visits to the patient does ease their mind, and it also mitigates the risk as well. Michael, I'll let you take that.
Yeah, I can start here. Yeah, no, that's great. So, I figure most of you are wondering, what does it take to start to use this sort of technology, and really what's the learning curve? Is it going to take a lot of my staff members out of the field to have to learn something? A lot of you might be familiar or have went through an EHR implementation that could be many weeks to many months to even possibly a year. I spent a lot of my past life leading EHR implementation, so I'm very familiar on that side. But most virtual care technology, especially Cinzy, is a very light lift. Now is really a difficult time to introduce new disruptive technology for what's going on in the world. You really want to introduce a platform that weaves into your existing clinical workflows. So not something that, maybe your staff or physicians or just other clinicians need to learn how to read documents or completely change their clinical workflow. You want to look for something like Cinzy that's really just purely a communication tool as well. And the learning curve is very minimal because really we operate on any device. And what that means is operating on a device that the clinician's comfortable with, whether it's a personal device or a company device. Okay. So most of our implementation can be done within a couple days. Our training for clinicians out in the field is usually averages around 45 minutes to get someone up and running. We do live training and guides as well too. The application itself is very intuitive and easy to learn. So we really wanted to take a simple approach to onboarding, remove a lot of the barriers of entry that most agencies see of, I don't want to add a new piece of technology to my staff members, right? But not all team members might be accepting, right? So really looking for that champion, looking for a vendor that does not disrupt existing clinical workflows, and showing how you're going to make your staff's life easier and more secure. Come across a lot of agencies that might not be using any communication tools at all, and they might just be using text message to discuss sensitive patient information, which we all know is obviously a big no-no. So, really putting those tools in their hands and kind of explaining it that way, that this is here to make your life easier, not a new tool to make your day busier, has really helped. And then just to start slowly, right? So there might be a little bit of learning curve. Everyone might not be on the same, the same level of being comfortable with technology. So just really starting slowly and rolling out, staff to staff communication, getting your folks comfortable on communicating with each other, and then rolling out communicating with patients. We have really seen work.
Excellent. Yeah, I'll let you start that one, Michael, too.
Excellent. So we pulled a couple quotes out from our clients that that we thought would be useful. Really to talk about the bottom right one first. The staff will buy in, with strong leadership and really establishing that internal champion. A lot of times that is usually the biggest stumbling block of agencies not identifying a couple people that are really going to drive the new use of the technology. Within that, patients will learn, as I mentioned, right? But the staff needs to learn and needs to buy in, because that is a huge thing here as well too, that, maybe my patients won't use it, or we're not seeing as big a participation rate as we thought we were going to see with our patient population. And if you usually look at that, the reason for that is because the staff haven't fully bought in. So, whether it's Cindy or whichever platform you go with, if you're looking to implement virtual care within your organization, absolutely identify a clinical champion that can get the staff excited, whether it's, some sort of contest of whoever can do the most virtual visits in a month, and then getting the patients positioned correctly with the technology. And really finding a vendor that can get patients on and removing that barrier of entry again for them, because you want to remove the barrier of entry for staff members, but then also for patients. You don't want to make it difficult for a patient to get onto a virtual care platform. I'll let you touch more, Shelley.
Okay, I just wanted to touch. There's the 3 bullets here: the position the positive with patients and establish the internal champion and the drive internal buy-in. And all 3 of those go hand in hand for me, because if you don't have one, your agency does need to create a culture that embraces technology. Nothing can sink a ship quicker than a bunch of negative Nellies complaining. This needs to start with leadership, and it can trickle down from there. And remember that these are adult learners, and their learning curve for each person is different. So don't shortchange education. And by what I saw with the Cindy product, it is relatively quick. We even had one of our clinicians go through this as well. It really is relatively quick to get them up and going. But I just didn't want to shortchange the whole idea of that education, because I think that can backfire on you if you do. So, and then I love this slide. The tipping point for telehealth. I think the genie's out of the bottle on this one. I think it's fair to say that the advent of telehealth has been just completely accelerated, that it's taken this crisis to push us to a new frontier, but there's absolutely no going back. Now, this is from our CMS administrator, Seema Verma. And while the genie is now just out of the bottle in many areas of healthcare, we all know that in home care, that genie's been out of the bottle for years. And we continue to make strides and use innovation to meet the needs of our patients. But we can, really appreciate her endorsement for telehealth. So thank you, Seema Verma. And then lastly, I just wanted to touch on a couple of areas here about reimbursement. As the CARES Act that was just signed, Congress has appropriated $200 million in funding to providers for a COVID-19 telehealth program. And I'm going to skip to the bottom 2 bullets here. I'll come back to the second one. And there are many states where Medicaid does reimburse for telehealth. I also will tell you, too, that when you're negotiating Medicare managed care contracts or any third-party contracts, you should be negotiating telehealth into those contracts as well. And then also to make sure that all your telehealth, your virtual care costs, all of those are included on your cost report. So currently, telehealth nor virtual care, it's not reimbursable under the Medicare home health benefit or for hospice. You do need a doctor's order, though, if you're going to use virtual care or telehealth visits, and have that on the plan of care. But regarding reimbursement, just yesterday or the day before, I can't remember, it was in Home Health News, they published it, that we are getting closer to telehealth reimbursement for home health. Bill Dombey, the president of NOC, discussed 2 possible options for reimbursement. The first being that they could reimburse us under the regular Part A home health benefit, or they could, like they're doing for other providers, reimburse us under Medicare Part B. So sit tight. This is really, really good news, I think, for us at this point, and there's more to come on this. So, Adam, I think at this point, unless, Michael, you want to make any closing remarks, I will turn this back over to Adam for any questions.
Appreciate everyone's time.
Adam?
Okay, great. Thanks, Shelley.
Mm-hmm.
Excuse me, Mike. Did you have anything else you wanted to add at this point? You said, or
No, that was perfect. Just appreciate everyone's time today.
okay, great. We do have one question that came in, and it looks like maybe Shelley, if you have any thoughts or can kind of touch on question is asking about any kind of insight for a way to write orders that would include virtual visits.
You would just write that virtual visit however many times a week that you're going you plan on doing that for the assessment, education, instruction, treatment, whatever you're going to be doing. But you would just write it in your orders just like you would any other visit. Whether if it's going to be a PT virtual visit, then it needs to be written as a PT virtual visit. If it's nursing, it should be written as an SN's virtual visit or telehealth visit.
Okay, great. Thank you.
Mm-hmm.
Another question here asks, maybe for either one of you here, any insight on webinars for training staff on actually conducting virtual visits? A couple examples being skilled nursing, PT. So again, any insight on how to best train staff for conducting these actual virtual visits?
I could start that, Shelley.
Okay.
Yeah, unfortunately, since the industry is pretty new, at least pretty new, just getting more popular and common on the post-acute side. Obviously, virtual care and telehealth has existed on the acute side for a long time now. The resources are kind of scarce unless it comes directly from a vendor that you're working with. Just thinking about our training platform, if you are going to be using virtual visits within our platform, like I mentioned, we have a live trainer. We do have training videos as well as training guides. So your best bet would be whichever vendor you decide to go with. They should be able to provide you those training materials. But unfortunately, off the top of my head, since every platform is very different, and the way the platform operates, there really isn't anything out there that I can think of that's generic for beginning virtual visits.
I don't know of anything either, but I was just thinking that, if you set up a virtual visit, you can let the patient know prior to that if they have any ability to do vital signs. So if they have a blood pressure cuff or a pulse oximeter, anything along, or a glucometer, if they could have those results ready for you when you call to do the virtual visit, you would want to assess the mobility of the patient. And you could, just use a regular physical assessment of the patient, go through the body systems. What's their color look like? What's their skin look like? Ask them about their breathing, any heart palpitations. Just go through your bodily systems and you're going to respond just, as if you were there, just like you normally would at a visit.
Exactly.
Okay, great. Thank you.
But that is something that we could look for in the future, maybe to do another webinar. I think that's a really good idea. So thank you for even bringing that up.
Great. Thank you. Shelley, this one may be geared for you, but Mike, feel free to jump in here. This question is around asking for some insight or maybe even an example of how to best incorporate telehealth into the plan of care with an intervention and goal for therapy.
Well, telehealth is the mode of the visit, but your goals really do not change. So, and nor will your interventions. If you're going to instruct a patient on what you do, when you're in the home, then you would provide that same instruction for the patient through telehealth or the virtual visit to be done that way. But yeah, your goal is going to be the same. It's just you're going to use telehealth or virtual care to do that visit.
Yeah,
so
and I can add more to. Oh, sorry, Shelley, go ahead.
No, I was just going to say it still can be to improve the mobility of the patient using telehealth or virtual care. And your interventions are still going to be the same, but the mode of the visit is going to be virtual and not in home.
Absolutely. Absolutely. No, and just to really add on what Shelley said, we work with a couple different rehab facilities as well too, and just thinking back to what they use. So like Shelley mentioned, having patients maybe show the exercises through the virtual visit, just so through the video. And then if you are using other communication modalities besides the video visit, if you're sending out any sort of text messaging or email to the patients, we've seen a lot of our clients, either send a YouTube video as well too, maybe after they leave a visit. Here's a reminder, here's how you perform the exercise. So a patient can, on their mobile device, whether they're on a tablet or a cell phone, click on the video, rewatch the exercise again, use that at home, and then show the therapist possibly on a video visit as well. I've seen it used a lot like that as well.
Absolutely.
Okay, great. Thank you. It doesn't look like we have any more questions at this point, so unless any come in here in the next few seconds, again, want to thank both Shelley and Michael for their time and sharing some of their insight here today. Hopefully everyone that joined us was able to take something away from today's session and ultimately, maybe something you can take and look to implement even within your agency or your organization. One other quick note, just want to hope you make note of our webinar that's scheduled for next month. It's scheduled for Thursday, June 18th at 1 o'clock Eastern Time. Laura Page Greifinger, who many of you I'm sure have heard present in the past, she's also Quartz founder, will be presenting on the learning curve, and she's going to touch on what we're seeing and hearing that agencies are both struggling and succeeding with 6 months now into PDGM. So should be a great topic, and Laura's obviously a wealth of knowledge as well too. So we look forward to having her share some insight there as well. One other question that just came in is asking about how visits are authenticated. I'm not sure if that's enough to kind of give you something to go off of, but again, just asking how visits are authenticated.
Sure. You would do you're going to document a visit just like you would if you were in the home, and so the signature of the clinician who has done the visit is should be sufficient for that. They're there, they do the visit, they sign off. And again, these, that would be for skilled visits. If you're looking for, aid authentication, that's probably not, I don't think would work well within, for that, that kind of visit. But you can always shoot me an email too. You see my email right there if there's something more that I'm missing, because there may be more in that question and I didn't get it.
Yeah, I was interested that pertain to the security side as well too, but I think you got it right, Shelley.
Okay.
All right. Well, looks like, again, that's it as far as questions. So thank you again very much to both Shelley and Michael for helping us out here today. And thank you again, everyone who joined us. Again, as we said, hope you enjoyed the presentation, found the content to be helpful and informative. And again, as we just mentioned, please don't hesitate to reach out if you do have questions for any one of the three of us, especially for Shelley or for Michael, or even if you wanted just to discuss more about how our teams, either at Court or Cincy, may be able to help assist your agency there. So thanks again, everyone. Hope you have a great rest of the day, great rest of the week, and hopefully get outside to enjoy a nice long holiday weekend here coming up. So thanks again, everybody. Take care.
Thank you.
Thank you.